Okay, good morning, everyone. My name is Roshni. I'm a PGY2 neurology resident. This morning, the case I would like to share is a patient I saw as a stroke code in the emergency department at 4:30 several weeks ago for memory loss. This patient is a 75-year-old gentleman, past medical history of hypertension. He was found to be confused but alert by members of his gym staff. He himself is aware of the memory loss. He last recalls going to his gym in the morning, but does not remember anything else, any other events of the day, including how he arrived at the emergency department. On his neurologic exam, he was alert and oriented. He was interactive. He was able to perform complex tasks. He told me his wife's name, his occupation, but he wasn't able to remember anything of the same day. And we had the same conversation several times. Specifically, I asked him if there were any stressful events going on in his life, and he told me that his son had been making some decisions that he did not agree with. And then we repeated that conversation several times, and he did not remember me on repeat exams. The differential diagnosis for what was really felt to be isolated memory loss without any focal neurologic deficit, TIA or stroke, focal seizure, post-ictal state, but also transient global amnesia. Specifically because isolated memory loss is a very infrequent presentation of acute ischemic stroke, and seizure was also felt to be less likely, just given how alert he was. His CT and CTA were unremarkable. His echo showed some mild LVH. His routine EEG was normal. Some stroke labs and his urine studies were all unremarkable. The presumptive diagnosis was felt to be transient global amnesia. This is a syndrome that lasts at least 4 hours, but no longer than 24 hours in duration, with complete resolution of symptoms. Classically affects patients ages 50s to 70s. It is anterograde amnesia during the attack, and so patients will have no recollection of the events that occurred during the memory loss. It is associated with, but not caused by, extreme physical exertion, exposure to cold water, sexual intercourse, severe pain, or emotional distress. The cause is still unknown. There are several mechanisms that have been postulated: venous insufficiency secondary to Valsalva maneuver, arterial ischemia, maybe a migraine or epileptic phenomenon, but again, none of these are definitively proven. And then imaging, MRI, specifically DWI sequencing, can show unilateral or bilateral punctate hippocampal lesions. These peak in detection rate on the 3rd day after the event, and while they are acute ischemia, they are reversible. So this patient's MRI did show bilateral punctate areas of acute ischemia in the posterior hippocampi. They did have an ADC correlate, though that's hard to appreciate. It is more obvious on the left side. So the takeaway points from this case is that transient global amnesia can be a clinical diagnosis, especially if there's isolated memory loss without any other deficit, with resolution of symptoms within 24 hours. This gentleman did have complete resolution of his symptoms. Does not typically recur, which is reassuring for patients. MRI may show, but not necessarily, punctate areas of diffusion restriction in the hippocampus. And transient global amnesia is not associated with any increased risk of stroke or seizure, and the mechanism is still unclear. Thank you very much.
Wonderful, wonderful. All right, Kim Johnson.
Okay, thank you, Rich. So it's my pleasure this morning to introduce Sterling Johnson, a neuropsychologist and the Jean R. Finley Professor of Geriatrics and Dementia in the University of Wisconsin School of Medicine and Public Health. He's worked there for the past 19 years in the Division of Geriatrics. He's the Associate Director and the Biomarker Core Leader of the Wisconsin Alzheimer's Disease Research Center, and also the Principal Investigator of the Wisconsin Registry for Alzheimer's Prevention, also known as WRAP. I think that's a very catchy name. And this is a long-running observational longitudinal cohort study of 1,700 adults who are enriched for risk for Alzheimer's disease due to parental family history. He's very distinguished in his career. His research has been continuously funded by the NIH since 1997. And currently he's named on 8 grants, has 25 completed projects, and exactly 333 publications. Sterling lives in Madison, Fitchburg to be precise, which is a southwest suburb on the edge of the University of Wisconsin, known for its local and state bike trails. His favorite color is blue, and his big COVID vacation escape is a planned trip to Maui for January. Lastly, I want to add that when we at Duke were in the very initial stages of starting our Duke UNC Alzheimer's Disease Research Center, Rich and I visited the University of Wisconsin's ADRC in 2018 and had the most gracious host in Sanye Asthana and the whole team there. Sanye is a geriatrician who's the ADRC director. He arranged multiple meetings for us, free lunches, coffee, and even a personal escort. As part of that stay, Sterling took time to meet with us and discuss the development of the RAP cohort. Back then, we were so honored to meet this giant in the field. And today we're equally honored he is making time for us as we embark on our newly funded ADRC. So welcome, Sterling.
Thank you, Kim. That was a wonderful introduction. I appreciate that. And I want to say congratulations to all of you on achieving the Alzheimer's Center designation and the vision that you've had and the ability to make that happen. It's truly phenomenal. I am going to talk today about some of our progress in Alzheimer's disease research, and I'm going to focus on the RAP study. Let me get back to the starting slide. Here's my title, New Discoveries in Preclinical Phase of Alzheimer's Disease, Findings from RAP. Here's my disclosures. So in 2021, here's how we think of Alzheimer's disease, or at least how I do. AD is defined by its dual proteinopathy, amyloid beta and tau. The clinical stage is something that can be characterized on a separate scale, and we disambiguate those two things. AD has a prolonged pre-symptomatic stage that may or may not progress to symptoms. And this pre-symptomatic stage is being studied by our field fairly intensively by many of us. We have PET and CSF biomarkers appropriate for AD, and I'll try to convince you of that today. Other diseases masquerade or co-occur. We have MRI markers of many of these, including some of the cerebrovascular diseases. We have promising markers for some of the other proteinopathies, including the Lewy body diseases, but we don't have biomarkers for other neurodegenerative diseases like TDP-43 disease. So it still becomes important for us to understand these syndromes clinically and also understand what may also be present in including Alzheimer's disease. Finally, I'll say Alzheimer's affects about 5.8 million in the US. This is a rough estimate. It's not informed by biomarkers, it's epidemiologically based. Let me just show you these slides. This is well known to all of you. I'm sure that we can examine Alzheimer's disease or ascertain the presence of proteinopathy with an amyloid scan and a tau scan. And that gives us a good approximation of what might be there on autopsy. And this is how clear it can be. Here's 2 participants. One on the left has the proteinopathies of amyloid and tau. The one on the right does not. And you can appreciate the difference between those. And this is the rough course of events. Amyloid precedes the tangles, which precedes the brain cell death, which then gives yield to the symptomology. All of this process from the beginnings of detectable amyloid to dementia might be somewhere in the neighborhood of 20 years or so. And how do we know this is from accumulating research in our field now. And I'll show you some of this now with the RAP study. We have been going for 20 years. We started the study before there was amyloid imaging. It was started by my colleague, Mark Sager, who's a geriatrician here. And when he retired in 2014, I took over the cohort. The study is looking at cognitive decline and answering this question: when is decline more than normal aging? What health and lifestyle and genetic factors increase or decrease risk for cognitive decline in AD proteinopathy? It's longitudinal, starts at midlife, and we're heavily focused on imaging and fluid biomarkers. And I think the reason this study is becoming more and more valuable to the field is that we know, based from the last slide I mentioned, we have a good idea that Alzheimer's just starts many, many years before its symptoms. And if the typical age of presentation to the clinic is in the late 70s, that means the disease started in a person's late 50s. And think about that. And that's a window of time that we might have to prevent this disease from occurring or reaching symptoms. So I just mentioned these goals: identifying it before its symptoms and identifying what factors might exacerbate its course or facilitate the proteinopathy in this. So here's some of the characteristics of our study and where our participants live. The average age is 67, 70% are women, 73% had a parent with presumed Alzheimer's disease as the cause of their dementia. This cohort resembles the state of Wisconsin. 40% are obese, 40% have high blood pressure, 10% diabetic. What is not resembling the state is that 41% of this cohort have the ApoE4 allele, and that puts them at higher risk for developing dementia. Okay, so some of the things we've done, and I'll touch on a couple of these today, is pinpointing, maybe that's a strong word, but we've been able to estimate the age that Alzheimer's starts from brain scans. We can identify cognitive decline before the MCI stage, and we're now studying the effects of health and lifestyle on cognitive decline. And the punchline that we're observing so far is that it definitely does impact cognitive decline, but not so much the amyloid proteinopathy itself. And I'll show you why that is here in a second. I don't think I'll take too much time on the research framework. This is probably very familiar to all of you. The ATN framework, amyloid, tau, neurodegeneration, is sort of how we think about the biomarkers. And on the right is the clinical staging of this, from unimpaired to mild impairment to the MCI stage and the dementia stage. The biomarkers that are good for ascertaining amyloid are these PET markers, and several of these are FDA approved. NAV 4694 is an F18 agent for PET that is not FDA approved. But in terms of the F18 agents, it's probably the best in class. C11 PIB, Pittsburgh compound B, is still by far the best of the amyloid tracers. It's got the best imaging properties. It's just very difficult to make and very finicky. In the CSF, of course, we've got the A beta 42:40 ratio and the p-tau to 42 ratio. And tau, we have flortaucipir that's FDA approved. We have PI 2620, and we have MK 6240, which is arguably the best in class, and the Roche compound RO948. And looking at tau in the CSF, you can use p-tau 181, p-tau 217, and p-tau 231. And 217 was, there was a paper published yesterday, I believe, in JAMA Neurology, suggesting that 217 was the best of these variants in p-tau. Let me go on here. Well, I'll just say, first of all, that candidate markers of N is still in parentheses because you don't necessarily need neurodegeneration to have the hallmarks of Alzheimer's disease. And neurodegeneration occurs later. It's not necessarily specific to AD, and a lot of work is being done on that. Okay, a little bit on what these tau tracers look like. This is a study from Rick Ossenkoppel and Oscar Hansen. And it's not really a study, it's more of an opinion piece, but they got all these tau exams from across the world and analyzed them all the same way There's different numbers in each of these groups. And this MK6240 group, you can see here, has the most intense signal, indicating higher dynamic range than either flortaucipir or PI 2620. The Roche compound also does very well. But there's several of these promising tracers for understanding tau pathology. Now, how sensitive they are to tau, how many units of protein tau in the brain do you need to evoke a PET signal, is something that needs to be studied further. We've been doing a lot of amyloid imaging and tau imaging, and this is just showing you what amyloid looks like in unimpaired people. This is a composite of 70 people here at the top and the left, and unimpaired amyloid negative people. You see an empty cortex around in green here in 253 people who don't have Alzheimer's. So this is very circular. MCI, this is what it looks like, a little more advanced. And finally, dementia, the amyloid continues to fill the cortex. Similarly for tau, among amyloid, those same amyloid positive people, you just see a hint of tau in the entorhinal area. And at the MCI stage, it's advancing, and at dementia, further advancing. And in amyloid negative people, you just really do not see very much tau at all in the brain. And there's a question of, should you even do a tau scan if amyloid is negative? This is those same people and same data showing the actual box plots. And interestingly here, the amyloid positive unimpaired people have roughly the same amount of range in amyloid as do amyloid positive people with dementia. And among the MK6240 tau images here, we see that the amyloid negative unimpaireds, by and large, 97% of these are tau negative. There's 3 that are confidently amyloid positive in the entorhinal cortex, and they're interesting individuals that we'll be studying more. The amyloid positive unimpaireds, more of these individuals have tau that is really developing in their brain, and then it's a stepwise increase to MCI and dementia. Interestingly, amyloid negatives with MCI, there's not a lot of these in this cohort, but none of them had any tau in their brain to explain their MCI. Well, that was a whirlwind through some of the PET tracers and how we think of this disease. Now let's talk about some applications. Let me start with this one, which was published in Brain last year. How does amyloid and tau status relate to cognitive decline is the question that we were addressing in this paper from Toby Bedhauser, who's a medical physicist and faculty here in the Alzheimer's Center. And this studied a bunch of healthy people from RAP who were cognitively normal, answering this question: do A+ and A negative groups and T+ and T negative groups differ in their cognitive trajectories? And I told you that RAP has been going for many years, and we've been following these people. So we're able to look back in time at midlife and see how these trajectories might differ. And here were the groups that unfolded when we looked at their biomarkers. Most of them were amyloid negative and tau negative. There were 5 that were tau positive only, 23 amyloid positive only, and 15 that had both amyloid and tau. And there's some of their demographic features. ApoE was more prominent in the amyloid positive groups. No differences in their demographics. And here's roughly what we see. The amyloid positive, tau positive group, this is the composite of their tau, and this is the composite of their amyloid. And you can see that looking at all these groups, that as you increase in your proteinopathy categorization, you actually also increase in the spatial filling of the brain across these groups on average. Let me go on to the next slide here. And this is the primary result of that study. And I want to call your attention to the group in red here. This is the amyloid positive, tau positive group. And remember, these are asymptomatic at their baseline. And the ones who are in triangles did finally reach MCI at their last cognitive assessment. And we're still following these guys. But on average, you can see that this group in red is showing unambiguous decline since midlife, since we started following them. And that is really not the case for these other groups here. And when we do the formal statistics, indeed, this group in red was declining 3 times faster than any of the other groups. So that's, in statistical parlance, a group by time interaction. And pretty compelling that when you have these dual proteinopathies, it's not benign, and the decline is happening well before you have MCI. So what else was going on? There was marginally more hippocampal volume loss in that group. There were no meaningful differences in their waist-hip ratio or cholesterol or BMI or blood pressure or vitamin D or glucose or any of those. But the strategy here was to stratify people into being amyloid positive or not, into being tau positive or not. There's probably a lot of information that we could obtain from looking at rates of change and looking at the magnitude and spatial signal here. And I want to now call your attention to this paper published by Rebecca Kosick and Toby Bedhauser, who shared first authorship. It was in DADM, one of the Alzheimer's journals last year. And this was compiling a whole decade of amyloid imaging in this cohort. And that decade is represented here, basically, especially in this lower left plot. This is the spaghetti plot of change over time within a person. Each line represents a person. If it's just a dot, that means we only had a single time point from them. What we were able to deduce, and I think what you can see just from looking at that left-hand plot, is that when you're amyloid positive, your rate of change is similar, regardless of whether you cross the line at age 50 or at age 80. Everyone seems to be accumulating, just eyeballing this, at the same rate. And indeed, when you apply an algorithm to this and center this based on when a person was estimated to have crossed that dotted line and become amyloid positive, you get a curve that looks like this. And this is starting to be reminiscent of the biomarker curves that we like to show and study in our field. And this plot here on the right is putting things in terms of amyloid time. How many years has it been since you crossed that line? And so here we see many these people who are amyloid positive have a duration of between, say, -5 and 30 years of being amyloid positive. The other thing we showed from this study is that you can estimate the age that a person became amyloid positive from a single scan. And this is because we can assume that the rate of change is going to be the same in everyone based on this. And that we also found that the longer you've had this, the more likely you were to have tau in your brain and more likely you are to exhibit abnormal cognitive decline. So we are not the only ones to show this. A few weeks ago, the WashU group published this plot, and this is from St. Louis, and this is from Wisconsin, and you can see that the rates of change are pretty similar. And they're able to show with their modeling an even tighter centering around this line. The data here at the bottom are spaghetti plots from the Mayo Clinic. There's an upper Midwest theme here, I guess, showing very similar characteristic rates of accumulation, a little more noise in the Mayo Clinic data. I think there's some subtle nuances in method we can talk about, but they are still nevertheless able to model change using similar algorithms and can come up with an age of onset and a disease duration. So what's the best way to go ahead and quantify these things, and how can we apply this kind of new thinking about amyloid, that you can characterize it in the time domain. We presented some work at AAIC this summer in Denver, and I want to take you through that fairly quickly here, and then show you some applications to the impact of ApoE and age and sex on amyloid accumulation. And these are by far the big three in terms of risk. ApoE is the big genetic risk factor. Sex is considered to be a risk factor where women have Alzheimer's disease, at least from an epidemiological perspective, more often than men. And of course, we all know this is an age-related disease. So the older you are, the higher your risk for developing this. Okay, well, we studied 3 different cohorts: the ADNI cohort, the Baltimore longitudinal study on aging, and the data that I've already shown you, the RAP study. ADNI, of course, has more people with dementia and MCI. This is the percent who are cognitively unimpaired at baseline. 40% were unimpaired. In BLSA, all of them were unimpaired at baseline, and RAP, nearly all of them. Different ligands, florbetapir was used in ADNI, C11PIB and BLSA, and in the RAP study, and slightly different ages at enrollment and big differences in sample sizes. I won't show you this. This is recorded, so you can go and look at this table if you want, but this is all the demographics of these 3 cohorts. But here's the spaghetti plots that I've been showing you now. You've seen the one for RAP before. It's a different color now, reflecting the ApoE genotypes. Same for BLSA and the same for ADNI. And I hope I'm convincing you now with just this raw data that amyloid accumulates in a fairly characteristic way. It's like getting on an escalator. You're going to go up at the same rate as everybody else. The only difference is the age you are at the time you get on that escalator. One thing to point out is ADNI is multi-site. These other studies are single site, and there's a lot more noise in the ADNI data. But we just took the spreadsheets. We didn't reprocess this. We took the spreadsheets from the website. But if you're planning to replicate this in ADNI, it's important to pick the right spreadsheet. This is a little sidebar into trusting what you can download from the internet. And here's one way of processing the data that's the most popular download from the ADNI website. It's the Berkeley cortical, actually it's this one here in the middle, the Berkeley cortical or whole cerebellum reference SUVRs for florbetapir. And you can see that there's a lot of noise in the way they process their data. But Eric Ryman, who has connections to Duke a while back, he's been making the point for years now that if you want to look at longitudinal change in the ADNI study, you're better off using a whole cortical white matter reference region. And when you do that, you see spaghetti plots that look similar to the other cohort studies that I mentioned. And that's what we used here in this modeling section of this talk. So we used some computer science algorithms. One of them was called ordinary differential equations with Gaussian processes, and one is a sampled iterative local approximation method. They're both non-parametric, they're autonomous, and we compared these to our more of a manual brute force approach of using our group-based trajectory modeling. And what we find is that, well, first, I'll just say what we did was we compared things forward, taking one scan and predicting their last available scan, and doing the same backward, taking their most recent scan and predicting their first scan. And we also did some out of sample modeling where you leave some of the sample out, you develop the algorithm on part of the sample and then test it on another part. So we use tenfold cross validation. Here's what we find in all of these cohorts. All of these methods perform similarly. The GBTM, which was our brute force manual approach, it had a harder time with ADNI because of all that heterogeneity. But the 2 computer algorithms did very well and agreed extraordinarily well too. In BLSA and in RAP, all these computational methods agreed with one another. The correlation between them, especially among people who do indeed have amyloid in their brain, is 0.9 or better with each of these. These open circles here, by the way, are trying to estimate an age of onset in people who don't have amyloid in their brain, and it's probably a futile exercise to estimate proteinopathy in somebody who doesn't have proteinopathy, and that's sort of appreciated here in these plots. This is just showing that if your rate of change over time is similar for E4 carriers and non-carriers, and that is seen in all of these cohorts. And also if you're male or female, your rate of change, again, is similar between these cohorts. We're looking at change in signal in the PET scan on the y-axis and the mean signal on the x-axis as a way of looking at change. And there's not a lot of difference between E4 carriers, genotypes, and between men and women. This is a sobering slide I want you to take note of, and this is the range of amyloid onset age across these cohort studies. And let's just take a look at ADNI here and look at the green box plot. This is the age of amyloid onset, like I said, in 3-3 homozygotes. Amyloid onset is estimated to be anywhere from early 40s to over age 90. This is the range of possible age of onsets. So when you do a PET scan on your patient and they're amyloid positive, it's just not enough information, because that amyloid could have been there, depending on the age they were when you scan them, that amyloid could have been there for a long period of time or a short period of time, depending on the onset relative to when you did that study on them. These patterns are showing up in BLSA and in RAP as well. There's roughly a 40-year difference, or range, I should say, between within which amyloid onset can occur. And also, I'll also point out that E4 homozygotes tend to get this disease about 10 years earlier than E3 homozygotes. And that confirms the very early observation of Roses and Strittmatter back in the day. Here's just looking at survival curves of becoming amyloid positive as a function of age. And you can see very similar curves for the three cohorts, showing that E4, the presence of the E4 allele exerts an influence such that you become positive earlier in life than if you don't have the E4 allele. And when you break it up by genotype, you see a similar stepwise function across all these cohorts. Now, what about time to impairment? Can we predict time to impairment by knowing a person's amyloid onset age and how long they've had it? And it looks like a little bit, to some degree, we can do that. And that was, I think, nicely demonstrated by the Schindler paper a few weeks ago from WashU, showing that you can, and that the longer you've had this disease, the more likely you are to have a CDR of 1. We did this in the ADNI study, and we find that the E4 carriers became clinically, they converted to symptoms, a CDR of 1, about 3 to 4 years earlier than the non-carriers. And that is further borne out here on the right, breaking things down by genotype. What about the effect of sex and age? Women tended to get impairment a couple of years earlier than men in the ADNI study, using this time from onset metric. And also, the older you were at your amyloid onset age, the earlier you were to, the sooner you were to get symptoms relative to your amyloid onset age. So age is indeed a risk factor, and if you get amyloid in later life, you're going to live with it with a less amount of time before you reach your symptoms. And that's further brought home by these two plots showing amyloid onset age on the x-axis and the median survival time for this one. And survival meaning survival to a CDR equal to 1, which is the clinical dementia rating scale. And the CDR of 1 is our benchmark for dementia, mild dementia. And the 10-year survival rate is again a function of age at which amyloid was onset. So I hope that's convincing you that the onset age and duration is perhaps a parameter that we can extract from an amyloid PET scan that might be clinically meaningful. What influences amyloid onset age? Pretty much just ApoE. What influences time from onset of amyloid to symptoms? It's faster, but not dramatically so in E4 carriers, slightly faster in women, and certainly faster the older you are. Here's another application of this, reminiscent of the Schindler paper published a couple of weeks ago. We've looked at CDR sum of boxes in our series here in Wisconsin. And we have amyloid chronicity plotted on the x-axis and the CDR clinical dementia rating, the sum of the boxes or how severe your dementia is. And if you get to 4.5, that's basically the threshold where your global score would equal to 1, and we would consider you to have mild dementia. And if you look at this mean curve in blue, you see it reaches 4.5, about 20 plus years. And but there's quite a bit of heterogeneity here when people's CDRs start going up over time. Some people have amyloid for quite a long time. Like here's a person who's had it 25 to 28 years roughly, and their CDR is not doing anything at all. It's getting better if you look at this plot. And here's a person here on the very far right. This is a professor of geology, I believe it was, and he had amyloid for quite a long time. And it wasn't until he was 30 plus years of being amyloid positive that he started to show symptoms, and then it went pretty rapid. So what we've been discovering is that the older you are, the more likely you are to be ahead of the curve here. In other words, less duration of being amyloid positive before you convert to symptoms. We also find that if you have white matter lesions in your brain, in other words, comorbidities, the shorter that interval is going to be as well, and you'll be ahead of the curve here, indicating shorter duration of amyloid before you reach symptoms. And that's because they may have dual diseases going on in their brain. I think I have one more study here to show you, and then we'll wrap it up. What increases or decreases the risk for AD and its cognitive syndrome of dementia? And these kinds of things on this list in the middle are things that we see in the media and that our patients ask us. Should we be, does sleep impact amyloid and cognition? Does physical activity? What about depression? What about the neighborhood you live in or your diet? Do any of these things slow amyloid onset or affect the symptoms? And we've been studying this. We've been collecting surveys since the start of the study, and getting indications of self-reported physical health and stress and mood. We have their zip codes, and we've geocoded everybody. We certainly collect their blood pressure and self-reported sleep. We put all of these things into a score called the Libra score, Lifestyle for Brain Health, which was published by Deckers. This is out of Amsterdam. Anyway, you can get a composite lifestyle score and health score based on all these parameters. And Carly Cody, a grad student in my lab, is working this up and is about ready to submit it for publication. What she finds is that if we look at incident of cognitive impairment, which was defined as reaching 1.5 standard deviations below the mean for your expected age and education and sex cognitively. The people who are at high risk on their Libra score, who have kind of that composite health indicator, they are reaching cognitive impairment at an earlier age than the people who are in the low risk group. So poorer lifestyle was related to cognitive decline over time, and it was largely, or at least partially, because that high risk group didn't have as far to fall cognitively, and they reached impairment earlier. We found, I'm not showing it here in this plot, but we found that these Libra lifestyle health scores were not related to amyloid rate of progression on the PET scans. It wasn't related to the onset age of amyloid or its duration. But again, it was related to cognition. So these lifestyle and health things that we might be able to optimize with our patients is going to improve the cognitive buffer. These data suggest it's not by altering their amyloid proteinopathy, but perhaps there's another way that it might be impacting and enhancing or improving their buffer and their resilience to cognitive decline, again, through other mechanisms. We haven't examined tau, by the way, and we're about ready to do that. And I think this is the frontier. Now that we can estimate when amyloid has started, what is it that we can do as individuals, and what can we counsel our patients to do that might prolong their healthy life span in the presence of amyloid positivity? A couple of cases. Here's a female. She's ApoE33. Her baseline assessment in RAP was 54. Her age now is 64. She's had 5 visits. Her baseline IQ was 120. Here's her in this big circle. She's had amyloid in her brain. We estimate that she's had, here it is over here, by the way, her amyloid and tau scans. We estimate that she's had amyloid in her brain about 18 years at the time of this PET scan at age 64. And she's floridly tau positive as well, but she's still very much cognitively normal, and there's no sign of decline in her. She's truly an anomaly, and she's one of the few that is not showing unambiguous decline in her cognition. Here's another case who reached dementia at age 74. We did a PIB scan with him at age 65 and again at age 74. And what we see here is that he was already amyloid positive at age 65, now much more so. When we began doing MK scans, we studied him as well with tau, and he's got a head full of tau, and this matches his symptoms. When we look back over time, we look at his CSF and his PET scans, he was positive on everything at age 65. But importantly, with the modeling that I just showed you, we were able to estimate that he probably became amyloid positive many years before he came to our attention. He probably became amyloid positive in his early 50s. And again, driving home the point that if we want to study this disease and make an influence, make a dent in preserving good years cognitively, we need to start early and find a way to prevent amyloid from accumulating and tau from occurring. So I'll just summarize that AD is detectable with biomarkers. I hope I've not been too dogmatic about that, but I think it's fairly clear from my vantage point. The A+, T+ groups have been declining from midlife for the most part, with the very rare exceptions. This framework, this biological framework, seems to work well, but binarizing people simply as amyloid positive or tau positive may not be sufficient, and it'll overlook important temporal information. As I demonstrated to you with amyloid, you can get a lot of information out of the temporal characteristics, age of onset and duration. And these are going to probably help us predict symptoms and counsel our patients and prognose more accurately than we can do now. We can get this temporal information from a single scan. This disease accrues slowly and predictably. It does not appear to be benign, but that might be too strong of a statement, because there's a subgroup of people who have amyloid on PET and they don't accrue tau, and they're, again, the frontier and really the area of most intense study in this field is these people who are resistant to becoming tau positive. And is it just a matter of time, or is there some protective factor at play that's going to cause that proteinopathy to not develop? There's many questions to address in the field still, and job security for a few years to come, despite important advances on many fronts. Just acknowledge the many people who helped make this possible, and the NIH funding that helped make this possible as well. I'll stop there and answer any questions you have.
Thank you so much, Sterling. That was wonderful. But it's a little daunting that it's 20, 30 years of data, and starting at the beginning of an ADRC, you got to start somewhere, right?
Absolutely. Yeah, that's right. Yeah. That amyloid data took us, we started collecting amyloid in 2008. And, but using this temporal modeling, you'll be able to predict back to midlife. And I think you guys have a few awesome longitudinal cohorts there that you might be able to leverage all that prior data.
All right, so questions. Joel, do you want to start with the questions?
Sure. I'm wondering if you've put your outliers, like your 120 IQ patient with pathology by scan, together and tried to do any assessment as to why that group of outliers are not being cognitively affected by the same pathology.
Yeah, we are in the process of doing that. We have not done that yet. I think it'll take a few more cohorts, maybe combining across some studies, and we're in the process of doing that. We have a collaboration with Marilyn Albert, the BioCard study and the BLSA study, and the ABLE study out of Australia. And we're going to try to find those outliers and see what it is about them.
Andrea Pizzaki.
Yeah. Hey, good morning. Your talk was amazing and eye-opening. I'm wondering if the grad student that has done your lifestyle factors analysis with regard to impacts on cognition and amyloid, do you have enough longitudinal tau data to be able to look at the rate of tau accumulation with regard to lifestyle factors?
We are, we're still collecting that. COVID threw us off a little bit, but we're doing the follow-up tau scans now, and we should soon have enough to look at tau over time. And tau is just not as well behaved as amyloid by any means. There's so much variability in its onset and pace of accrual. So we'll see. We'll see. I hope that there's something there.
Heather, this is Heather Whitson, our ADRC director.
Hi, Sterling. What a great talk. That was just a fantastic talk. So my question is, as I think you know, I'm a geriatrician like Sanjay, your director. And, you know, we think of chronological age and biological age as really different things. And I noticed in one of the slides, there was a label that said biological age, but I think it was what we would refer to as chronological age. There are, you know, there's a sort of burgeoning field of geroscience around trying to be able to measure one's biological age with serum markers and other biomarkers. My hypothesis would be that one of the factors that contributes to when people get on the amyloid elevator is their biological age, not their chronological age. And I wonder if that's something that you've considered looking at, or if the tools are there to be able to do that in terms of banked serum, and I think it might also be something that would potentially contribute to time that people tolerate amyloid before they become tau positive or before they show symptoms?
I think that's so intriguing, and you're right. That was mislabeled. It was chronological age, not biological. Yeah, we've been collecting blood every time they come in. We collect serum. We have their DNA. We can look at. We're collecting PBMCs on some of these individuals. So there may be a way of looking at some of these markers of biological age from these peripheral markers to study that. We have not done that.
I would love to talk to, I think we're talking later today, and I'd love to talk more about that. There's a particular tool that was developed here at Duke in the Dunedin study, which is a birth cohort of people with data from birth to age 45 that developed a really predictive biological age marker.
Great. I look forward to talking about that.
That's good. Thanks.
Congrats again on center.
Yeah. And I'll take the opportunity to ask the last question. You know, when we see patients in clinic, I'm always telling them the amount of atrophy on their MRI doesn't really correlate with whether they have a disease or not. And you didn't mention MRIs much today. And, you know, the whole neurodegeneration of the ATN is kind of related to MRI atrophy. What are your thoughts on that?
I think that's another area of job security and it really intense scientific investigation. We know that there's some prototypical cortical signatures and cortical thinning patterns and hippocampal volume loss and some things that you might point us towards Alzheimer's disease and atrophy and symptoms. But as you're alluding to, they're just not specific. And if they have hippocampal atrophy, is that because they have TDP43 or alpha-synuclein in that area around the.
What about even between cognitively normal and cognitively not normal?
Yeah, there's, if assuming that Alzheimer's is their trajectory, there's still a lot of variability there. There's a ton of it.
Our feeling, yeah. Okay.
And I think it'll depend on who you talk to about that. Brad Dickerson at MGH has made some incredible gains in that space, and Howie Rosen and others at UCSF are doing this in the FTLDs and are finding a lot of mileage out of just looking at different patterns of atrophy and where the cortical thinning might be taking place to help gauge what kind of disease they have and how fast it's growing or progressing.
And growing. So, all right, Sterling, we got you on the schedule for later on today. And again, from everyone at Duke and UNC, thank you so much.
You bet. Thank you. Appreciate the invitation. Happy to do it. Talk later today.